I would like to invite Dr. Nitin Parikh, Dr. Vimal Prajapati, and Dr. Dharmesh Prajapati. All viewers are asked to continue here. Don't leave the screen at all, because you are going to see the wonderful discussion, very hot, very lucid, and always charming. So Dr. Nitin Parikh, Dr. Vimal Prajapati, and Dr. Dharmesh Prajapati are being invited as a moderator. And Dr. Mridul Sharma, Dr. VC Chauhan, and Dr. Jishan Mansoori, they will be the chairpersons. Please. Chauhan sir, kindly introduce the speaker. Your mic is off, sir.
Dr. Chauhan, unmute, please.
I'll unmute myself. Now, can you hear me? Hello?
Yes.
Yes. So, see, it's a privilege to introduce Dr. Anil Jain. And probably all Ahmedabad people should know that Anil Jain is from Baroda, and he started his career from Baroda and with me. So, myself and he were together at a Mayo Hospital in Baroda many years ago. It was one of the first cardiac surgery set up in Gujarat, actually. And today, I will not go into detail what is written here, but I can say Anil Jain is one of the most skillful surgeon. And if you consider single-handed, and I think he does the highest number of surgeries per month compared to anywhere in the country. And he's one of the bold surgeon as well. I can consider he has done about 35,000 plus surgeries. And he is not only a great surgeon as far as cardiac surgery is concerned or bypass surgery is concerned, but he does a lot of other complex surgery also, including valve surgeries. And unlike other surgeons who are always very skillful with the hands, Anil Jain is skillful with his lips as well. So whenever he does any debate, whenever he does any lecture, he will talk like any cardiologist is talking about surgery. So I would consider him as one of the great orator and speaker as well. Now, should I introduce the other speaker, or first Anil Jain will talk and then we have to introduce the other one?
Let Dr. Anil Jain talks and then you introduce.
Yes, yes, okay.
Dr. Mansoori will introduce.
Yes, okay, yeah.
Good evening, VC. Thank you for that lovely introduction. And I thank Kamal for the opportunity given today evening to speak on this very important debate. That is, what is better for a 45-year-old man? And I'm sure all of you know what's better for this patient, but still let's debate it out. So can you hear me? Can you see the slides, Kamal? Kamal, is it seen? Hello?
Not the slides. We can see the 4 folders.
No. Okay, 1 minute. Let me get back.
You need to share your screen.
Yeah, 1 second. Just a minute. Kenny is working on it. He's with me. I'm not a very tech savvy guy, so I've got Kenny with me too. Can you see it now, Kamal?
No, sir.
Not yet? What's the problem, Kenny? 1 second.
Sir, first of all, open your PowerPoint and then share your screen, sir.
Okay. Sorry, I'm not the real tech guy, but I have someone working with me.
Dr. Jain, can I go ahead and present my meanwhile? If the
Maybe you can do that.
You want the help?
Just 10 seconds if you see whether it works. Otherwise, you go ahead and.
Kamal bhai, anesthesia de diya.
Now, can you see it? Can you see it now, Kamal?
No, it's like LIMA. The chest is closed, I can't see.
You have to now, because today cardiologist.
Yes, now I can see. So when I do angiography, then only I see. So
okay, now you can see it.
Go ahead. We can see.
Okay. Good evening, everybody, and I'll straight away go to the debate. Give me an extra minute if surgeons are not as good as speaking as cardiologists. We get our facts a little mixed up. Well, here we are trying to debate whether a 45 years old male with unstable angina and a left main lesion, what should be the course of treatment? And I don't think this is a matter of debate. I didn't want to debate it, but Kamal said, okay, let's debate. Hence, I'm here. CABG, according to me, is the only option for this. I would take you all back to pathology, and I'm sure that you all know the 4 stages of atherosclerosis. And you know that up till the stage of foam cell stage formation, you're not going to see that on the angiogram picture. It's only when finally the plaque progression occurs, there's degradation of extracellular matrix, and there's a rupture of the thrombus, you will be able to see something. Second, I'm sure all of you are aware that the coronary artery disease migrates from the proximal part of a vessel and smoothly moves distally. So usually the first few centimeters of all coronary arteries are affected in coronary artery disease. So the vast majority of plaque burden is found in the first few centimeters of any artery. We are talking of this Medina 110 lesion where, there is a left main lesion and there is an LAD lesion and the circ is normal. So I would like to ask all of you, okay, do you think everything will be normal? If there's an LAD ostial lesion and left main ostial lesion, is there no atherosclerosis in the circumflex? It's not seen visually, but I'm sure there would be disease available, progressing in that circumflex also, which is not visually seen. It's in that sub-angiographic stage. I know you talk subclinical, but I'm sure there would be disease in sub-angiographic stage, which you cannot see. So maybe placing a stent from left main to LAD would cover the angiographically visible lesions, but it may not cover the lesion that is sub-angiography or not visible on an angiogram. And a normal ostium of the circumflex does not mean it is normal. There could be atherosclerosis slowly creeping into that ostium. So now if suppose Dr. Kamal is to do an angioplasty for Medina 110, is it simple? This is the flow chart of a Medina 110 angioplasty. You want to go from left main to LAD, then you want to do an IVUS into circumflex, you want to put an IVUS and OCT in LAD, and you're going to do all this complex picture, and you should an FFR of 0.8, and then you will be able to accept it. So imagine you would need IVUS, OCT, your experienced operators are going to be required, and then you're going to be able to plasty this. Look at this picture. This is how Medina 110 would look. Do you think there is no disease in circumflex? Would you call this a normal circumflex? On the either lips of the vessel, you have disease. So I even believe that there is nothing like a normal circumflex. So for a lesion like this in a young non-diabetic 45-year-old guy, when memory is fantastic or internal memory grafts will be fantastic, what is the problem? What would the survival be? I want all of you to take a guess. So let's see what are the results of coronary bypass surgery in left main coronary artery disease or in CABG in general. What are the results of CABG? I'm talking of 20-year-olds. So I've gone to old papers. So 67% at 20 years are asymptomatic after CABG, and at 10 years, nearly 70% of vein grafts. And this Gerard Laurie talked about vein grafts. 70% were patent at 10 years. Means such results. We have third study with 17.6 year survival, and patients completed nearly their life cycle after coronary bypass surgery. So this is the results of coronary bypass surgery. Look at angioplasty. I am just presenting some left main angioplasty results. Look at all these trials. This is IRIS Main. IRIS Main tried to compile the data of various studies, and they look at 1 month, 2 months, 3 months, 6 months, 1 year, 2 year, 3 year, and bare metal stent, and then they come to drug-eluting stents, and then they come to a second generation drug eluting, and we talk of 1 to 2, 3 years. I am talking of 20 years. We have to talk of a patient who has to live for 30 years, not 10, 2, 3, 4 years. So these studies give some data, and everywhere they try to compare. TLR was better, TLR was more, mortality was less, mortality was more. At 3 years, are you talking at 45 years? You want to talk about 3 years? We're talking 3 years. Okay, let's look at MAIN compare. That was a big study trying to compare left main disease angioplasty versus bypass. Okay, now what do you see in that? They tried to use bare metal stents, and at 3 years, they saw 82% need for target vessel revascularization. At 3 years, 82 means 18% needed revascularization. So extremely poor result as compared to CABG. Even when DES was used, the TLR rate was higher, target vessel revascularization rate was higher in PCI than CABG. So you've done it for CABG. You've done revascularization. That's what you need. You want to vascularize the patient, but that's the very procedure you're having to repeat at 3 years. We are talking of 30 years. Let me conclude. So left main compare said that the rate of target vessel revascularization is significantly lower in CABG group. And You're trying to say, okay, the rates of mortality and morbidity and stroke may compare with CABG. You're not saying they're better. This study did not say it is better. It just said that the results may compare. Then there was this huge Nobel trial, and this Nobel tried to compare what is what and whether CABG left main angioplasty is better or CABG is better. In that, let me tell you, the average age of patient was 66 years. We are talking of 45 years. And all these patients, I have not mentioned that slide, most of these patients had one memory artery graft at least. And everybody, a lot of them had the left main bifurcation stenting. So what are the results? Look at MACE. What is the rate of MACE for PCI? 28.9%. Mortality, higher in PCI. Non-procedural myocardial infarction, higher in PCI. Total repeat revascularization, higher in PCI. And stroke results, imagine stroke. You have more stroke than in PCI than in CABG, which is very surprising to me. And this is where a population of 66 years old was included. So what did Nobel conclude? Nobel concluded that CABG is superior to PCI, and repeat revascularization was higher after PCI compared to CABG, and everything else was similar, or PCI was not non-inferior. Not that PCI was superior in any one category compared to CABG. Then a study was done called Excel, and I'm just going to show you a comparison of what Excel was. Excel and Nobel trials were then compared. Now look at the red line that I made. It is said that revascularization, even Excel, was 12.9% in PCI compared to 7.6% in CABG. Also, death, MI, stroke was higher in PCI than in CABG. So we are talking about people dying, and we are talking about people needing repeat revascularization. So is that good? Then somebody else thought, okay, let me look at everything. Syndax, Pre-Combat, Excel, Nobel. And what did they conclude? They said that though PCI and CABG may have similar results in early years, they still have higher stroke rate. Imagine higher stroke rate with PCI than CABG. Are we wanting patients to have MI also and a stroke also? And again, they say there is a higher rate of revascularization. And this is not me. This is the cardiologists who compare all three trials, Pre-Combat, Excel, Nobel, whatever they could get on their fingers. And then again, Syntax trial said very clearly, only patients with less than 25 Syntax had any chance of anything being better than CABG. Otherwise, there was no way. If a patient had any extra lesion, then there was no purpose of trying to do CABG in patients with Syntax core. Imagine any patient having Syntax of more than 20, 22 should have CABG according to Syntax trial. And I don't think that's something that's well practiced. And again, PCI versus CABG, revascularization, repeat revascularization is very high. In Nobel, again, they said, in Nobel, the MACE at 5 years, the MACE, death, and stroke rate was higher than CABG. So imagine, again, another meta-analysis and review all these studies. And they said that percutaneous coronary intervention in CABG, so comparable, just 2 minutes more, just few slides more, is similar. PCI is better for revascularization. So multiple trials, multiple studies show at 3 years and 5 years, we talk about 3 years and 5 years, and I'm talking of 20 and 30 years. Why does that happen? That happens because CABG is a procedure that works beyond any lesion. And it is said that there are many subclinical lesions that lead to MI. It is lesions that are less than 50% that are responsible for more MI than the lesions that are critical. And these lesions are not covered by CABG. This is what happens. The stent is placed here. There is a subclinical lesion beyond, and that is why you get an MI. Whereas what surgery does, it goes distal to all the disease in the coronary artery and puts a mammary artery bypass. Hence, the patients survive longer and do not have repeat myocardial infarction. So there is no PCI data that validates the requirement. Surgery provides a surgical collateralization beyond all disease coming in the proximal artery. Hence, it works. I will leave you this very, very small video clip, which I want you to see and digest. It's about a picture from Amitabh Bachchan. I'm sure you're aware of these lines, and I will leave you at this. Just listen to this.
आज मेरे पास IVUS है, रोटाप्लेटर, एंजियोग्राफी, एंजियोप्लास्टी, पेसमेकर है. क्या है तुम्हारे पास? मेरे पास माँ है, LIMA.
Thank you very much, everybody, for your kind and patient hearing. But this is what surgeons have. We just have one LIMA. Thank you very much.
Excellent talk by Dr. Anil Jain. I think he has given a big pass to Professor Kamal Sharma.
I didn't have much time. I could have talked a lot.
Yeah. Over to Dr. Kamal
Within
Sharma.
10 minutes.
Can I have my
time.
slides?
Please go ahead, Dr. Kamal.
So, yes, Dr. Anil Jain has given us a Ma, and I'll also give you another Ma. It's a matter of time. And he beat it around the bush. You know, he talked about circumflex, minor disease, major disease. आपने नहीं देखा, मैंने नहीं देखा, मैं अंदर जाके देखूंगा, आप बाहर से नहीं देखते. I'll show you what we see. So, next slide. So we are looking at a 45 male left main 110. Next slide, please. So this is what it looks like. Anil Bhai is not shown an angiography. He's not going to talk. He's going to talk about disease here, disease there. This is what it is. You can see absolutely clear circumflex here, and then I will show you the results. This is what Medina 11 is, and this is what we are talking. You have disease in the left main, and you have disease in the ostium of the LAD, but no disease in the circumflex, and we are debating it. I could have debated a much easier task, you know, ostial left main, shaft left main, but I thought I'll discuss something bigger. If I win this, I of course win that. Next slide. So when a patient, he said patients die. Who dies more? Let's see this. So there are two currently available STS risk calculator for an isolated CABG, which is available online, and you can Google and they calculate it for yourself. For this case, same as for the PCI, there is another score. My patient dying for a PCI for a disease like this, risk is less than 0.8. What is risk in CABG? It is 1.4%. I know Anil Bhai might have much lesser, but it is surely much more than what a cardiologist averagely would give as compared to an average cardiothoracic surgeon, which is double the mortality you will have in PCI, in CABG as compared to PCI. And not even talking about renal failure, strokes, prolonged ventilation, scar, and that all we'll cover. Next slide. So that is the one reason. So you said higher mortality, absolutely wrong. You were talking about a combined 8 MACE point, which was driven by repeat need for revascularization. आपने तीन चीजों को combine किया, उसमें सबसे ज्यादा component repeat revas था, उसकी वजह से total बढ़ गया, आपने बोला mortality, but incorrect. Second, guidelines. All the three guidelines, go to next slide. All the three guidelines talk about, next slide. They talk if you have isolated left main or ostial mid shaft, of course, that's class 1 in next slide. But even if you have to do 111, even then it's 1 in next slide. 110. So you have syntax score, fantastic. One thing I liked about his talk, he talks about as a surgeon syntax score, fantastic. What is the disease syntax score for this lesion? It is of course less than 22. Go ahead, next slide, which is again class 1A. You can go ahead and do the angioplasty for 110. 111, the syntax would be higher, 110 will not be. Next slide. So if you go to third, Excel trial, again, he was conveniently, you know, taking out the things that he wanted to talk about. In Excel, the primary endpoint occurred was similar at 3 years. They were not higher. The only thing that was higher was need of repeat revas. If you ask a 45-year-old man that you're twice likely to die after my surgery, though it is only 1.5% compared to 0.8 with Dr. Kamal, and you are more likely 20% chances to get us and another angioplasty, what would he choose? I think answer everybody knows. Next slide. He may not mind a repeat revas, but he will surely not get his chest open, which in the Shinto religion, people believe that the soul escapes and man becomes soulless. Next slide. So you have again other trials like Nobel and pre-combat, which again Dr. Jain was selective, choosy to talk about. Of course, number of patients each, but these were complete revas. Next slide. These were non-STMIs and these were not isolated 110 Medina. And at 5 years, only thing that was all inclusive, all kinds of patients, triple vessel, only repeat revas was higher, nothing else. So if this patient, even I assume that he has got very bad disease, which angiography also does not pick on the circosteum, he may worse at the case require a repeat revas, but he's surely less likely to die. Next slide. Look at pre-combat again at 5 years, difference again was not statistically. So he said 15%, Hamara 17%. This is not statistically different. Even if I was to point out next slide, I can talk about higher MACE MI rates, which surgeons say, no, aapne to cheating kiya, MI ka definition badal diya in Excel trial. Because they said, no, biomarkers can rise up to 10 times after bypass, but angioplasty, if it rises 3 times, I will call it MI. You have different roles and different goals and different definitions to define MI, and still you lose the ground in Excel trial, and then you say, no, this is cheating. You define higher cutoffs for us, otherwise we will not participate in it. Again, he mentioned 2 important trials, Iris main and main compare. Again, he talked about the total trial. He talked about bare metal stents. I'm again talking about left main 110 subgroup. Next slide. And both of them clearly show that in these trials, the difference was not significant. Both of them had similar outcomes. If you look at mid-cap versus PCI-DS outcomes, the use of bare metal, there was relatively short follow-up, inconsistent use, and adjunctive medical therapies such as aggressive platelets. That's why you had CABG better outcome in these trials, not in when you use it compared with the drug-eluting stent. Next slide. Now, this is with mid-cap. I'm not even talking about, what about mid-cap surgery? People talk about, oh, chota hole karke kar denge surgery ke baad. Dr. Jain is a good surgeon, so he doesn't do that kind of a thing. But there are surgeons who beat around the bush saying, aapke itna bada chhed jo wo पैर में करते हैं वो छाती में उतना ही छोटा छेद करेंगे. But that is not how it works, because you have bigger incisional hernias, dehiscent seromas, and what is the incidence? 9% versus sternotomy, which is Dr. Jain is very good. He gets very lower exploration rates for that. But what about mid caps? Even they are more painful. Next slide. If you look at another reason, these are the references. I'm not talking out of the book. Next slide. And next slide. The Syntex trial, again, subgroup, if you go back, can you go back? If you can look at the Syntex trial, a 12-month rate of MACE was not different between PCI and CABG. Next slide. Amongst that, again, 35% were left main patients. Next slide. This is again outcomes you can see. So Syntex care here, what is Syntex score? It is 11. 11 Syntex, of course, he gets a PTC. Why should he get a CABG? Next slide. And what were the stents used? Texas. Texas is like, MiG-21, flying coffins, as they say. And now you have best stealth Rafales, which you can go and bombard anywhere, the top of the technology stents, which are much, much superior. Next slide. And that's the reason you look at the new generation stents, the struts are going, the polymers are bioabsorbable. The generation is much beyond of the drug. There is no drug left beyond some time. Next slide. And if you see the metal drug polymer triad, which is the debate which is already happening in the other hall. Dr. Jain might be listening to that, because I'm not sure whether he's liking my talk or not. But that is another important aspect of the stents. Next slide. And yes, your ma. मेरे पास माँ है. कौन सा का माँ है? वो patient माँ patient. That माँ is with the patient. And that is MA card, not the BIMA, LIMA. It is MA of MA card, where the angioplasty is also free. Dr. Jain is, probably not available in MA card. Next slide. So that MA card actually brings down the cost. It's done for free, and he gets a stent for free, and he doesn't have to pay anything for that, getting his chest open. What is the duration of hospitalization? 24, 48 hours. He may get another revasc at the rate of whatever we discussed, maybe 5 years, 10 years, or 20 years. And left main, for the CABG, he'll be in hospital for 5-7 days. For a poor guy who is having MA, the MA card MA is not going to earn for his own MA at home to feed her MA. So for that MA, the government has given one MA, and that MA is better than your LIMA. Next slide. So this is the pain and the scar. How is he going to earn and feed his MA? Next slide. What is the anesthesia? This tube, you explain the surgeon to the patient, you will put a tube under your throat. He'll say, no, sir, if you can do something with just giving an injection and my arm radials, he's good enough. Next slide. What about imaging? He said, the more plaques I can see. Dr. Jain, I don't know, how do you see? Because the plaques are inside the coronaries. So you are actually doing palpography. You're just palpating the coronaries from outside. You're relying on the angiography, which may actually not pick up. But I can see because I can image. I can go inside and see where the plaque starts, where it ends, whether it's calcified, stage 1, stage 2, stage 3, 4, which Dr. Jain very well said. Imaging is in my hand. The day surgeons will start doing imaging while doing LIMA, I will start arguing in favor of Dr. Anil Jain. Next slide. And of course, why hunt the mountain for a small mole? Chota sa lesion hai, kyun saap chhati chirte ho? Next slide. And what happens for that angiogram? This is a case which was published nowhere else but in India only. Anush Gupta in European Heart Journal published. Aapne bola sar pinch ho jayegi, dekho B mein ho gayi. He did an FFR and did a check angiogram at 6 months. And you can see the spasm or the plaque shift had not resulted in any ischemia, and the artery was still patent. Thank you very much. Next slide. Thank you. Thank you very much. Thank you.
I think this was a debate between really two bulls, both expert in their own fields. And I agree, Ma and Ma both are important things. But see, I would consider in this patient, Anil, in this patient has non-dominant circ, non-diabetes and very young age. So I would also personally go in favor with what Kamal Sharma has said. But had it been for 65-year-old diabetic, dominant circ and significant lesion in circ, I would definitely go with the Anil Jain. So fortunately, I have both the options. Now I'll ask another thing. Anil, you said disease progress from proximal to distal, but we have seen that once you do surgery, the disease progress proximally as well. I've seen many patients with 60-70% block in proximal area. You put LIMA and proximal lesion becomes 100%. So the nature provides disease from proximal to distal. Surgeon reverses it from distal to proximal. This is just my observation. Now I'll ask Dr. Madhul Sharma to go ahead and give his comments.
Virendra, give me a chance. Huh?
The problem is that we do not have surgeons.
Always getting chance.
I'm the only surgeon, but I'll hold the fort. Don't worry.
Yes, yes.
The problem is we do not have surgeons as capable as Dr. Anil Jain is in majority of the centers in Gujarat. So majority of them undergo angioplasty and encouraged by the results over many, many years. We have now started doing left main angioplasty in very, very complex situations also. And the results have been gratifying, not only clinically, but even angiographically. You see 1 year, 2 year, 5 year down the line, you're pleasantly surprised to see well-flowing stents. So all depends on how good you are at performing such complex angioplasties.
Of course, I would like
See,
to
for
add
a good LIMA, you will require Anil Jain, but for a left main angioplasty, any Kamal Sharma, any Tom Dick Harry can do the left main to LAD and it will work. So excuse me for saying that.
Yeah, technology has spread much faster amongst the cardiology community. The surgeons, we are seeing many surgeons, surgical patients, they are coming back in 6 months, 1 year with closed grafts.
The only thing, Kamal, how would you explain if you have to do angioplasty for left main in my Yojana, you will not be using IVUS or any of the things, and you will use only particular type of stent, and may not be, they will not use the costly medicines, and stent thrombus is a real issue, and patient can die suddenly, and we often don't know this type of risk. That's
so good question. Good question.
My question, Virendra, that was my question. You stole my question. I've got some other question.
So good. I have to answer only one question. That's good. So prasugrel in generic is as cheap as clopidogrel twice a day. So don't even think about that. He's not going to be on drugs. Number one. Number two, imaging. There are enough data to now compare CT to compare stent boost with IVUS, which shows it as non-inferior, which every now cath lab has. So you can do a stent boost, especially when you're doing a left main to LAD and you're not doing a crew bifurcation. Probably imaging may not be compulsory, but you would always encourage it to do. Again, third thing, at institute, we do imaging in left main bifurcations, even in Yojana. So it's a misnomer to assume. And I didn't say I'm going to operate at Sal. I can operate this patient at UN Mehta. What's the problem with that? I'll go and operate at UN Mehta. I'll do imaging even in my Yojana, no problem. It can be done. Prasugrel can be given. Even ticagrelor is given in Yojana at UN Mehta. And in private also, prasugrel, all of the cardiologists are using in Yojana with a generic prasugrel. What's wrong with that? And so if you have prasugrel, which is now more potent than ticagrelor, antiplatelet. Sorry?
The need of imaging is only in very few selected patients. We are not doing it in majority.
Absolutely. When you're doing left main bifurcation, you're doing ISR, then probably yes.
Otherwise, globally, less than 5% of individuals globally who are undergoing angioplasty undergo any intravascular imaging.
But I agree.
Probably overhyped technology. We talk in conferences.
But stent ka bhav kam ho gaya, imaging ka baat chalu ho gaya.
Practically, we don't do.
Okay, I guess I should get my couple of minutes after you discuss options of angioplasty and stuff like that. See, couple of points I really want to make up. They say early mortality, CABG 1.4%. That's according to the scores, but actually a young patient would be low for renal failure, low for stroke, low for everything, and he usually does well. But we are talking of 30 years. What happens over the next 30 years to him? Not early mortality and long-term mortality. Look at all the trials, I read a lot even before this particular debate. They have mentioned very frequently that there is need for revascularization beyond the stent, not the stent. The stent may work. It is not the problem of the stent. Again, that's what I want to pressurize with all of you. The problem is disease. Disease usually progresses in the first few centimeters of any artery. It may keep progressing from LAD ostium downwards, circ ostium downwards, and that is not something you or I can prevent. That's a normal aging process, normal way the pathology works.
Okay, so my question for that would be...
Kamal, it's my 2 minutes. Please.
Go ahead.
So that's something you can prevent. What happens with using a mammary artery graft, and that is why mammaries have shown better long-term result, is mammary goes beyond the few first centimeters of the vessel, and it tries to bypass even areas that in future disease can develop, and it's like a form of surgical collateralization. There is this lovely paper from Donest in 2019 that was in JACC. I can send you the link, where all your major cardiologists were, and they mentioned that. So the mammaries go beyond. Second, the mammaries themselves secrete nitric oxide, prostaglandin, other things which prevent progression of disease. Hence, we have 15 years patency rates of mammary artery. I'm sure you all have done plenty of angios of mammary arteries that are flowing. Anything may close, but the mammaries work. And nowadays, surgeons are getting better at bilateral mammaries. Again, you say anyone can do a left main angioplasty. Do you think a 99% left main and some person sitting with a cath lab all alone in a remote area is going to have the guts to put a stent there in case the patient crashes, IBP, this, that, blah, blah.
They are doing.
Third, I know they are doing. Third, the problem of imaging. If you want to do the ideal thing, like all the results have shown, now you say, okay, we can do this type of imaging, that, see, some imaging in circ is required. And let me tell you, circ MIs are bad. Whenever the circ closes and there is an MI, these lead to mitral regurgitations, problems, aneurysms, heart failure. These would happen. And we are talking of a 45-year-old patient. And there is no clinical data. I searched the entire net beyond 5-7 years for such disease. CABG, 20 years, 30 years, easily. And we are talking, if it was Kamal had said 65 years, a 70-year-old guy, I would not have debated. I would have said, I want to be a ranchod. I'm going, I think a plasty is good. You all do plasty and get away. But you are talking about a 45-year person. And in India, they can't afford. Ma is okay. Ma Rivasana is okay. But if you want to do a good job in a private sector hospital, patients can't keep affording coming back. Oh, sir, mera stent wapas band ho gaya, extend circumflex mein. It is closed, one more stent in LAD. A mammary artery graft, a bilateral mammary, and I've seen my patients live 20 years. Yesterday, I got a call from a patient I operated in 99, and he died a day ago, and the son calls me and says, you had predicted 20-year survival. He lived 20 years and he just died. So there have been, and you know, there is ample data of CABG and especially LIMA alone pulling a patient off for 20 years. So I really believe it's a good strategy. Maybe stents over time will develop. You will need more advanced stents, better technology. Someday you will get there. But as of date now, for a 45-year guy, if I don't want him to risk his life, I would do a CABG. That's it. Thank you very much. I know. And one more point, which I wanted to point about antiplatelets. Now, just now I was hearing your debate. There can be bleeding. We can use dual. We can use single. We can use prasugrel. We can use ticagrelor. So your debates even on antiplatelets are not over. Where is the question? Where is with simple CABG, a simple aspirin, even if it stops, these limas keep flowing. So your debates on antiplatelet is not over. Where is the question of angioplasty to left main, circumflex, complex? And I don't know how much antiplatelet the guy will have to eat. He'll get a couple of ulcers in 30 years. He'll get bleeding piles. He'll get something else, and he'll get into trouble with a CV otherwise. So it's not that I'm against it. The procedure is excellent. Technology is progressing. But I still think for a 45-year-old guy, I think CABG is the better guy. Thank you.
See, Anil, I have one question to you. Whenever you put LIMA to LAD in this type of situation, the LAD disease progresses. And many times LAD get occluded. Now patient is left main going to the circ, and there is a tight lesion in left main. So what will happen to circ in that situation? And that
in this situation, I would have grafted the circ.
That way.
I would have done a bilateral mammary, LIMA to LAD and LIMA to OM. When we do a left main, we always put a graft to OM. There is no doubt. And that you talk to proximal, it is not because of LIMA the proximal. That is the disease.
Will you graft an RCA, which is 50% also in this patient? Suppose he has a 30% lesion on RCA. Will you graft? No, you will not graft that, but you will graft a circumflex, even if it does not have a disease. How does it justify?
50%. In fact, I'm going to do a case on Monday where the patient had an angioplasty, similar angioplasty. His LAD is now 99%. His RCA stent is flowing, and we are wondering now what to do. He had a left main to LAD plasty. I don't bring the film here. but the LED osteum is now 99%. So it's the disease progresses proximally. That is why you see only the distal lima flowing. The proximal disease is bound to progress, come what may. It progresses right in all angiograms.
Disease progresses even more rapidly in the native artery when you graft a not so critical disease. That also we know. If you graft a 30% RCA, then either RCA will close or the graft will close. That everybody knows, because competitive flow is not going to flow. So circumflex is anyway a placebo that you're protecting. Your only thing that why you're doing it is doing it for lima.
Then I have Kamal to plasty, don't worry. You are there, yeah, and your dual empty platelets, they will win the day.
Just one request to Kamal, don't do plasty for left main in my yojana, because I have seen patient who goes for my yojana, angiography, angioplasty, when it gives surgery, 7 days stay, they go to the deluxe room. So these are the people there. Anil Jain would get patient in deluxe room. Don't do it in my yojana.
It's true. They get angio in Ma and they come CABG in deluxe room. I'll show you these angios. There was a patient from Anand, and I don't want to name the cardiologist. He was in a good hospital in Zydus Hospital at Anand, and his son was in Ireland, an unstable angina. He got angio in Ma. His son flew in from Ireland, and they had a CABG in a deluxe room in Epic.
So, yes, sir, I'm here only. I'm just listening.
Yeah, you're there. You know about that patient. So that's what happens.
We'll have to close the session. We are already short of time.